It's me, Jen, again, and today we'll be discussing another non-surgical treatment option for thyroid nodules. Dr. Agustin Andrade will teach us more about thyroid laser ablation after this. Dr. Andrade is chief of the Endocrinology Department at Mount Sinai Medical Center in Miami, Florida, and he has been in practice there since 1997. He holds the unique distinction of offering his patients not one, but two non-surgical thermal ablation techniques for thyroid nodules. Providing both thyroid RFA and laser ablation, Dr. Andrade can choose the treatment option best suited to a patient's individual needs. In today's episode, we'll learn just what laser ablation is, how it compares to thyroid RFA, and which procedure might be best suited to your thyroid nodules. Let's meet Dr. Agustin Andrade. We're going to talk about laser ablation. This is kind of a new topic. Patients are asking questions, and I want to answer their questions. So you're going to answer their questions for me today in this video.
With pleasure.
Awesome. Okay, well, let's get right into it. Let's talk about how did you find out about and start your training in laser ablation?
That was back in 2017. We have all the studies from the Italians and the South Korean that they were doing this treatment. And since I was bombarded with so many thyroid nodules, at that time, we didn't have any treatment. The only treatment that we had was the alcohol injections that, as you know, is not that very effective, and maybe it's more effective in cystic lesions, but not in solid lesions. In 2018, I was invited to Italy, and I went to Turin. So that's when I was trained for the radiofrequency ablation. And then since then, I was one of the first 3 doctors that started doing the radiofrequency ablation in the United States. And then after that, it was in 2019 that the Italians, again, another group, they invited me to start performing the laser. I saw a couple of cases that they did in Italy, and I was amazed because it's so easy doing this procedure. We did like 3 or 4 cases in Italy, and then I moved to the United States, and they imported the machine. And then the Italians came in again to Miami, and we started doing the first cases over here.
Tell me then, since you were trained in both radiofrequency and laser, what are some of the key differences and similarities between these two treatments?
Let me start with the similarities. Though the similarities are that both reduce the volume of the nodule, and in cases of toxic nodules, they both normalize the TSH by 50%. But now the radiofrequency ablation, I use it for very large nodules. For whatever reason, I've been involved in very large nodules that I'm consulted. So for you to have an idea, most of the nodules, they are 3 to 5 centimeters. No, to me, they give me the 5 to 10 centimeter nodules.
Wow, those are big.
So no, but I enjoy doing that. So that is similarity. But now, what is the difference? The difference is that with the radiofrequency ablation, you have a moving shot technique that you go with a needle, you burn, you retract the needle, and you burn the nodule little by little. The laser, you put a fiber inside of the thyroid, and you start burning the nodule from inside out. There's another difference. The radiofrequency ablation, you need to have a training. You need to be well trained, and you need to have an expertise to perform that. The laser, which I think is going to be the future in endocrinology, not for the big nodules, but for the medium-sized and small nodules, you put the fiber. You don't need to have that expertise and that training. So it's a difference because it's easier for the doctor to do it. And number 2, what I see is that when the patient has a contraindication for the procedure, let's say that the contraindication for radiofrequency ablation include pacemakers, pregnancy, okay, And sometimes patients that they cannot extend too much the neck because they're old or they have neck problems, then the laser works very well because you just put the ultrasound, you put the fiber, and the patient is talking to you, but like you and I, while I'm burning the nodule. So that is the difference and the similarity.
It would be, to my understanding, the radio frequency is a free-handed technique, while the laser is a set it and forget it.
That you can say it that way because
Okay.
you have a track that you put exactly the needle where you want to put, then you start burning the nodule with a pedal that you push, and you see the nodule how it start to burn. The other one is like it's like I call it like a Michelangelo. You have to burn, and you can go to the capsule, no? Sometimes with the laser, you cannot go exactly to the capsule, and so you can leave a rim of thyroid nodule that is not burned. That is why the reduction is not as much as the radiofrequency ablation because you leave that little rim of the thyroid. The important thing is that the score of the cosmetic score that we call it is exactly the same. So at the end of the procedure, the patients are very happy with the reduction because in both cases they have about 50 to 70% reduction of 50% of the volume because that's the way that we measure the success, a 50% reduction of the volume. So with the radiofrequency ablation, you can achieve that in about 80%, and with the laser, you can achieve that between 50 to 70%.
What about selection of patients? How do you decide, aside from the size, as you said, larger nodules being more suited to radiofrequency, how do you choose patients for these two different procedures?
As I said, the one contraindication of the radiofrequency ablation is a pacemaker and pregnancy. So that's easy to say. So if you have one of those, you cannot do the radiofrequency ablation. The other is if the nodule is not big enough and the patient cannot extend the neck because they have neck problems, laser is better. And the other thing that I've done a lot is patients that they cannot stop fully the anticoagulation because they have atrial fibrillation, they have a stroke, so they need a little bit of anticoagulation, is laser. You cannot go and then move and retract the needle because there's more chances that you can have a hematoma.
Gotcha.
Whereas with the laser, you go, boom, you put the fiber, and then there is the risk of a hematoma. I don't want to say that is zero, but I haven't had not even one case of minimal hematoma with the laser.
How many cases have you done of RFA and laser?
So the RFAs I have, because I'm working in that statistic right now because we're about to publish that, we have 60 patients and 100 nodules. And the laser, I have 20 patients. And the reason behind this is because with the radiofrequency ablation, since I do a lot of large nodules, the radiofrequency ablation is the way to do it.
But would you say, are you more in favor of, as now that both of these procedures are available in the United States, patients are no longer having to wait for these kinds of options to be available. So would you say, are you in favor of treating earlier when nodules are smaller before they get a chance to grow to this very, very large size?
Jennifer, I had that question every single day. Here's my answer, okay? So I think that the radiofrequency ablation and the laser, what we call the thyroid ablation, if we combine the two procedures, has to be done when the nodule is more than 3 centimeters or when the patient is having symptoms, when the patient is having pressure, cannot swallow well, or have difference in the voice. So if the patient is having symptoms, if the nodule is more than 2 centimeters, we can do the radiofrequency ablation. The other exception to this rule is when the nodule is overworking, toxic. When the nodule is overworking, we don't care about the size of the nodule. We can apply any size and do the procedure. What I want to avoid, since I'm teaching this to doctors, I want to avoid that the doctors start performing these procedures in patients that don't require the procedure. And since this country could be money driven at times, I don't want the doctors to start doing that. That would be my dream. So if I can teach and everybody do the procedure when the patient is symptomatic or is more than 3 centimeters, I'll be happy. I don't want the doctors to start doing procedures in 2 centimeters nodule without symptoms. That is not ethically correct.
I think that's quite reasonable because you run the risk of overtreating disease, and there's always risks and benefits that you have to weigh out. Is the treatment warranted? Are the risks of the treatment outweighing the benefits? And when you have those very, very small nodules maybe being treated too early, is that maybe not the case?
It's not the case. I mean, because it's possible that that nodule is going to be like that for the next 15 years. What is the gaining of doing the procedure? So it's the size and the symptoms, unless there is toxic nodule, then any size.
Can you give us an idea? I know it's going to vary from one practice to another, but can you give us an idea of the difference in costs between the two procedures, RFA and laser?
Both procedure cost more or less the same, is between 5,000 and 6,000. When I had to treat nodules in both sides, we charge, for example, $7,000 because you do the two treatments at the same time. But usually is between 5 to 6,000.
It's not really a matter of, if say I'm a candidate and I would qualify for both procedures, it's not a matter of choice based on price.
No, not anymore. As a matter of fact, the laser for nodules that are medium size or large size is very costly, because when you use more than 2 fibers, the price of the procedure is more than the radiofrequency ablation.
I see. Well, let's talk about one thing that's kind of on everyone's mind right now about laser, and we're all kind of confused about it, is the fact that there's now a code for laser, but there's not a code yet for RFA. Can you talk with me about that some?
You're right. There is not a code for radiofrequency ablation. The American College of Physicians just approved a code for the laser procedure that is going to be effective next year in January 2022. That is going to be a different ball game, and we have to see what happens. Hopefully, with that, all the insurance will start paying for this. That I think for the insurance is going to be very practical, because a surgery costs between $14,000 and $25,000 in the United States, and this procedure only costs between $5,000 to $7,000. So that's what I was saying to a particular insurance. Last year, I saved $1 million just by preventing surgeries.
That's incredible. And does that cost include just the cost of the surgeries, or would that even include the cost of the medication the patient would require for the remainder of their life?
No, it's only the surgery.
Wow.
Then if the patient has to take thyroid medication forever, that will be another cost.
Even more.
And without talking the complications from the surgery, that you have more or less about 3 to 4% chances to develop hypoparathyroidism. That is when the PTH is not working and you have to take calcium forever, or when you have a vocal cord problem, you have to use collagen in the vocal cord. I mean, that happened. Thanks God, the chances of that is more or less than 5% of all the procedures.
Wow. So just thinking cost benefit analysis here, it makes good business sense for insurance companies to pick up and pay for these procedures. Hopefully they'll see that before too long.
Correct. I mean, it's brainless for the insurance not to accept this procedure.
Wow. Well, let's talk a little bit about the step-by-step process. You already explained a little bit about inserting the fiber into the nodule. Can you just kind of guide us through a little bit about what a typical patient experiences during the laser procedure?
So the patient comes, they lay down in bed, facing up. We put lidocaine in the capsule of the thyroid. We insert the fiber through the guider. There's a guider in the laser. So we choose several tracks that we have available in the laser screen. We decide which is the best track that will take the whole nodule. So we put a needle. Through the shaft of the needle, we insert the fiber. None of that is painful. The patient doesn't feel a bit. The only thing that the patient is going to feel is the lidocaine. And then once you put the fiber, then you start the illuminations. You decide how many joules you're going to use, and then we start illuminating the nodule, and you can see that there is a change in the color of the nodule. They start getting from black to white, and that is because it's destroying the whole nodule. Usually, the dose that we use in thyroid disease is about 200 joules to 500 joules per milliliter of the volume of the nodule. So many patients, they require 7,000 joules, other people require 14,000 joules. The time that we spend on that is about 20 to 40 minutes. Let's say that we use 2 or 3 fibers when we make everything faster. If we use only one fiber and we have to reuse the fiber, then it takes forever. So that's what we want to use, 2 or 3 fibers per nodule.
So you're limiting the amount of time that the patient is laying
Exactly.
there and the amount of lidocaine needed. And that makes sense to me. And I would assume that similar to RFA, as this tissue is burned, it's going to just gradually dissipate over time after the procedure? Or is there actually a cavity burned into this nodule from the ablation?
No, there's not a cavity.
Okay.
Sometimes what happened is there is, well, the burning of the nodule, you see like a scar tissue inside of the nodule, but there is not a hole. Let's put it inside of the nodule. Once I finish the procedure, the patient stayed in my office for about 15-20 minutes. They are discharged with Tylenol and they put a little bit of ice there. And the chances of having pain for less than 24 hours is about 12%. Very few people, they have pain for more than 3 days, but nothing major, nothing that they have to go to the hospital. At the end, one of the differences that I see between radiofrequency ablation and laser is that there is less swelling in the skin of the neck when you use laser versus the radiofrequency ablation.
Is that because you're not moving the probe around during the procedure like you do in RFA?
That's exactly right. You're not moving the probe during the procedure.
That makes sense. You insert the probe and then you leave it there rather than having to move it around, so you're disrupting the muscles less.
Yeah, you always have a little bit of inflammation after the procedure in the radiofrequency ablation, unless the nodule is very small. When the nodule is very small, you just introduce the needle, and you can finish that in about 15 minutes. You can finish a nodule.
So the patients don't really feel any pain or discomfort during or after the procedure?
During the procedure, they feel discomfort. For me, that is very important in radiofrequency ablation or in laser. When the patient is having discomfort in radiofrequency ablation, I can decrease the voltage. And in laser, I also decrease the volts that I'm giving, and I retract a little bit the fiber, and immediately the pain goes away.
Okay, so pain is something that you want patients to let you know that they're experiencing.
More than pain itself is discomfort.
It lets you know how you maybe need to customize what you're doing in a different way.
Exactly.
Okay.
In the past, there have been studies that they have been using anesthesia to do the procedure. Sometimes people that use anesthesia, not in the United States, but in several centers in Italy, they have problems because the patient was sleeping and then the patient may have burning in the skin or problems with the voice because the doctor didn't know that they were close to the vocal cord. What I teach all the doctors that are doing our procedure over here is patient has to be fully awake.
I agree. I've only heard of a few instances of patients being put to sleep for RFA, and I'm always very surprised when I hear that.
Yes, that shouldn't happen. I mean, the maximum that you can do is sometimes we can give a little Xanax 2 hours before the procedure just to calm a little bit the person if the patient is a little anxious, but we'll seldomly we use that.
And especially when the patient's not having to lie there for a very long time, it's not terribly, I would think, anxiety producing. What about the size reduction? How long will patients have to wait before they see reduction in their nodule after laser ablation?
So to compare with the radiofrequency ablation, you have in a month you have a 30% reduction more or less in radiofrequency ablation. In 3 to 6 months you already have a 60-70% reduction. In the laser you have a 20% reduction in a month. You have a 50% reduction in more or less in 3 months, and 50 to 70 in 6 months.
So it's pretty comparable, is what it sounds like.
It is, but always, I achieve more a little bit more reduction of the volume with the radiofrequency ablation. But again, going to the cosmetic score of the patient, they're both very satisfied.
Yes, any patient that is experiencing that bulge in their neck is going to be very pleased when that
It's
bulge
going to be
goes.
very pleased with either procedure.
What about the risks or side effects of laser? Are they similar to RFA, or are there any differences?
Well, laser have much less side effects. So the radiofrequency ablation, the only side effect that you may have is the hematoma, the bruising, generally speaking. I never have any case of vocal cord problems, but that is described in the literature. There is a burning on the skin that you can have in both when you're retracting the needle and you burn the skin. But usually that happens in patients that are under general anesthesia or sedation. So that's with the radiofrequency ablation. With the laser, you don't have, I don't want to say never. I never have any hematoma. It's described that you can have hematoma, but it's very uncommon because you're not changing the position of the needle. What I see is there's a little discomfort on the laser more than the radiofrequency ablation. Even though you have more hematoma in the radiofrequency ablation, sometimes you have a little bit more of discomfort, not pain, but usually it's less than 24 hours. Major complications, zero. And the likelihood of having hypothyroidism is about 3 in 1,000. And that happened only in patients that they remove by surgery one side of the thyroid, and the patient have a huge thyroid, and you're burning the remaining of the thyroid. So in that case, you're going to have hypothyroidism, but that is extremely uncommon. And definitely you don't have any hypoparathyroidism or vocal cord problems like surgery. And you're functional the next day, not like surgery that you have to be in the hospital and you're out of combat for a week.
What about thyroid cancer? Do you see an application for thyroid cancer with laser?
So I have treated several cases of thyroid cancer, microscopic thyroid cancer, in the patients that they didn't want to be on observation because of anxiety, because it's important to say that microscopic thyroid cancer, you don't have to treat it. It's observation only, unless the patient has lymph nodes. That's a different story than the patient needs surgery. So, but I have cases that patients, they don't want to have that little thyroid cancer, and they want to opt for something else. And the something else, there are only two options: is alcohol injections that we had tried before, and the radiofrequency ablation. But the radiofrequency ablation works very well on the thyroid cancer. I haven't had one case of cancer myself treated with laser. I'm sure when I have the perfect patient for that, I will do it. But for that, I prefer to use radiofrequency ablation because I have more flexibility. You have to not only treat the nodule, but I usually go like a 2 millimeters around the nodule and burn everything to ensure that everything is well treated.
How many cases have you done of cancer?
6 cancers.
You know, that's getting to be a very common question in our group. Patients are eager to find physicians who'll offer RFA for their microcarcinomas. So I'm excited to know that you've done that, and I'm sure you'll be getting requests after this video gets published. What about, are there any applications besides thyroid nodules, like you were talking about lymph nodes, or what about parathyroid adenomas, where you could use the laser for treating those?
So this is my personal opinion. I don't advise to use thyroid ablation in the parathyroid because it's very close to vital structures, the sympathetic ganglia and the recurring nerve in the other side. But they have done it. I prefer to do that surgically. I have not done any case of parathyroid with thyroid ablation, either with radiofrequency or with laser. I'm not too pro of the parathyroid and the thyroid ablation. Maybe if that is done, should be in a person that has all the contraindications for surgery. And if you do that, you have to use hydrodissection of the posterior part of the parathyroid so you don't damage any nerve. There is something that is called the danger triangle. You have to be sure that you respect that. So if the parathyroid is very close to that, I would use the radiofrequency ablation, and I will be sure that you do a very good hydrodissection. So you put fluid to separate from the vital structures before you do that.
You mentioned that you are training physicians in this procedure in laser ablation. Can you tell me more about that?
Is doctors that are interested into that, they come to Mount Sinai. Is a full day. We usually provide 3-4 patients, and so we teach them how to insert the needles, how to illuminate how it works, the laser. The cases that we have had, all the doctors are super happy. We have 1 or 2 doctors, they already bought the machine and they start using this. The way that I foresee this procedure is so easy. You don't need training, that I think that long term, maybe more doctors are going to be using this, because if you can do a biopsy of the nodule, you can use the laser.
Excellent.
So that's what I foresee. That there are going to be more doctors into the laser than into the radiofrequency ablation.
Well, I think they both definitely have value. And I'm interested because you do both. What actually drove you to decide I'm going to do both of these?
The radiofrequency ablation, when they came to the United States the first time, they were interested on me. I was doing a thyroid clinic even before all these turmoil started happening. I was very keen into the thyroid. That was my passion. So it's not that I decide to become a thyroid doctor out of the blue. Like sometimes many doctors, they see this and they say, "Oh, I'm a thyroid doctor." So I've been doing only thyroid for the last 15 years of my life, when I was doing the alcohol and everything. I have a patent for a needle for biopsies. When the doctors cannot get a good sample, I have a needle that can get a better sample.
Interesting.
With all that, the companies called me to be part of the radiofrequency ablation first, and then once I started doing the radiofrequency ablation, the people from laser from Italy, they thought I was a good person to introduce the laser into the United States. And that's the way that I became the first doctor doing laser here in the United States.
Do you know of any other physicians currently that are offering laser in the United States?
Yes. So right now, there's a doctor in Missouri that is doing laser.
Well, we definitely want to know who's doing this so that we can let patients know, because patients are always wanting to know, are there providers near me? That's one of the biggest questions we get. How can patients reach you if they want to find out if they're a candidate for laser or RFA or any other things that you offer for nodules?
A good way is to use our telephone number, 305-672-7560, and they can go through the web, thyroidcenter.net.
You mentioned a minute ago, before we started recording, about Medicare. So what do you think the process is going to be regarding getting Medicare and then insurances to cover this? And how far out do you think we are realistically from seeing more insurance coverage for these procedures?
We will have to see what happens next year with the code that we have.
Mm-hmm.
And once we have the code, we start billing. Once Medicare see that there are several doctors billing for this, they're going to start looking into this, and they're going to start thinking about paying. But for that, we need Congress people. I don't want to get into that, but we need Congress people to help us. If 1 or 2 people that are in the Congress have this problem and they have to run through this problem, that will help a lot.
I agree. That's why I'm passionate about this, because I've been through it and I know what it's like, and I know that I'm not the only one. And so I'm not going to stop talking about this. This is important. It's been important to me, and my experience in the Facebook group has been that it's important to a lot of other people too.
No, Jennifer, this is a great favor that you do for the American people. I mean, think that 60% of the American people, they have thyroid nodules. Out of these nodules, about 11% of the nodules are big enough that they need some sort of treatment. If we can avoid unnecessary surgery, thinking that 60% of all the surgeries are unnecessary. So 60% of every surgery in the United States are for benign nodules that could be done by thyroid ablation.
That's amazing.
We're talking about is like a $2 billion that the insurance company are paying for unnecessary surgeries.
Wow, change needs to happen.
Yeah.
This has been very interesting. I really appreciate you helping me learn more about this procedure. It's just been not something that I felt like I could answer a lot of questions about. So I'm glad to have this video now as a resource for patients. I hope that physicians will come down to Miami and get training and learn the procedures so that there's more providers available in the United States. So thank you for what you're doing.
No, Jennifer, thank you for all the efforts that you're doing to change the medicine and endocrine practice in the United States.
Thank you so much for watching. You can help others tremendously by sharing this content. Never forget to educate yourself and be your own health advocate. Now, watch this next video right here.